Hello everyone. Today we'll discuss about benign liver cell tumors. The benign tumors in the liver are about twice more common than that of malignant ones. The most common benign tumor in the liver is hemangioma. The second most common benign tumor of the liver is focal nodular hyperplasia. The most common malignant tumor of the liver is actually metastasis, mets from various organs, especially the colorectal mets. The most common primary malignant tumor of the liver is hepatocellular carcinoma. In this lecture, we'll talk about the commonest benign tumors of the liver, hemangioma, focal nodular hypoplasia, and liver cell adenoma. And then we'll see what are the common features in this and what are the distinguishing features of these from one another. Let's dive into it. We'll start with hemangioma. So, hemangioma is the most common benign tumor of liver. This hemangioma is more common in females than in males. For that matter, all the three benign tumors of the liver are more common in females. So this is almost three times more common in females than in males. And it usually occurs in the age group of 40 to 50 years. Right? It is basically in the middle age group. But some hemangiomas can also be seen in childhood. Few hemangiomas are also seen in childhood. In childhood, they contribute to about 12% of all the liver tumors. And these childhood hemangiomas, they could be a capillary hemangioma or cavernous hemangioma. These capillary hemangiomas are usually small, they are not significant, and they resolve on their own. But the cavernous hemangiomas are large and they can grow in size. So any hemangioma which is more than 5 centimeter is considered to be a giant hemangioma. So these hemangiomas, when they are large, they will exert one mass effect. But more importantly, as they keep on increasing in size, the AV shunting becomes more and more. So there is arteriovenous shunting. So in the body, wherever there is a significant arteriovenous shunting, the blood takes the shortcut. Usually the blood has to go from these veins into the inferior vena cava, then into the heart, then into the lung, then back into the heart, then into the systemic circulation, and reach arteries and then into the capillaries. So this cycle is there. But wherever there's AV shunting, the blood takes a shortcut, and because of this, all the significant AV shuntings will lead to hyperdynamic state. Because of this hyperdynamic state of circulation, these children are prone for congestive heart failure. So that is why these giant hemangiomas in the children should be treated with embolization, and there should be medical therapy for CHF. Right. So that is in childhood. In adults, these hemangiomas have a slow and indolent course. So any benign tumor of the liver has got two risks. So we fear about the risk of rupture and the risk of malignancy, them being transformed into malignant neoplasm. The risk of rupture in an adult in hemangioma is very rare. Hemangiomas rarely rupture, and there have been no cases of malignant transformation of this hemangioma in the liver. So it has got no malignant potential, and the risk of rupture is very rare, and thereby they have a slow and indolent course. So these hemangiomas are basically congenital vascular malformations. So as years add on to life, they keep growing slowly, and their growth is only by ectasia, not by neoplasia. Right? So whatever the blood vessels are there in that hemangioma, they get dilated and dilated and dilated, and because of this ectasia, they enlarge in size, but there are no neoplastic changes that happen in the hemangioma. Right? So that's why it said that they grow, they enlarge by ectasia rather than by neoplasia. So that is why if you look at the histology of these hemangiomas, there are these dilated blood-filled sinusoids. So there are these small vessels which are dilated and are filled with blood and are separated by thin fibrous septa. Right? So there are dilated blood-filled vessels separated by thin septa. So that's what it looks like in histology. So when it comes to clinical features, again, most of these hemangiomas are asymptomatic. And when these hemangiomas increase in size and they produce mass effect, so because of that, there could be pain abdomen, or if there is a gastroduodenal compression, there could be vomiting. Sometimes there can be acute presentation with fever. So that might indicate a thrombus in the hemangioma, right? So it presents with fever, which mimics the pyogenic abscess. So there is a known syndrome that is associated with hepatic hemangioma, which is called as Casabach-Merritt syndrome. So this Casabach-Merritt syndrome has the following components. It has got hepatic hemangioma, consumptive coagulopathy, and thrombocytopenia. Right? So this is the triad of Casabach-Merritt syndrome. And because most of these are asymptomatic, they are incidental findings on investigations. So you take an ultrasound because it is hemangioma, which is a blood-filled sinusoid. So there will be a cystic mass in the liver. For all these benign tumors, a contrast enhanced CT or contrast MRI is the investigation of first. So you take CT and MRI, there will be enhancement of these lesions, which is at the periphery and it is nodular. So there are in the liver, these hemangiomas are of usually solitary. So these hemangiomas are usually solitary, but sometimes they can be multicentric and they are multiple. And these have equal distribution in the right liver and the left liver. So because there is blood inside, there is peripheral nodular enhancement on the outside. So there is peripheral nodular enhancement here. And because there is blood inside, now that will appear hypodense or hypointense compared to the rest of the liver parenchyma. So that is what happens. There's a peripheral nodular enhancement, and because it is made up of these small vessels, they take up dye slowly. So this peripheral enhancement is seen in a delayed phase. Right? So delayed enhancement in the periphery, which is of nodular type, with hypodensity or hypointensity in the center of the lesion is characteristic of a hemangioma. Right? So even still the diagnosis is in question. You can get a radioisotope labeled RBC scan. So this is the most accurate test. MRI has got sensitivity of 100%. Now this radioisotope RBC scan is the most accurate test to diagnose a hepatic hemangioma. So, by these radiological investigations, a hemangioma can be diagnosed, and FNAC or biopsy is not needed. Also, it is contraindicated. So, because of high risk of rupture and bleeding, if such is performed, FNAC and biopsy are contraindicated. Right? In all these benign tumors of the liver, the LFTs will be normal. If not, there will be slight rise in the enzymes. And the alpha fetoprotein will be totally normal in contrast to that of a malignancy. Now, how to treat this patient? Right? So, because they have got, there are two things that need to be considered. One is the risk of rupture, second is risk of malignant transformation. So, rupture is very rare and malignant transformation has not been seen yet. So, that is why If these patients are asymptomatic and it is an incidental finding, you don't have to do anything. So just follow up of this patient is sufficient. But if these patients are symptomatic, even in symptomatic patients, for example, there's a patient who has come with a vague upper abdominal pain. You get a scan done and scan shows that there is hemangioma. Even in such patients, that hemangioma might not be necessarily the cause for symptoms of these patients. So there might be some other cause for the symptoms of these patients. So that is why it happens in more than 50% of patients that there is an alternate explanation for the symptoms of the patients. So that is why whenever there is a symptomatic patient, an ultrasound or CT shows that there is hemangioma, you search for alternate cause, other causes which can cause the symptoms to this patient, right? So if alternate cause is not found, right, or if the symptoms persist, or if it keeps on increasing in size, causing mass effect, or if it is a part of Kesselbach-Merritt syndrome, then all of them are indications for surgery. Right? So the patient has got symptoms, and there is no alternate explanation for these symptoms. There is persistence of symptoms, and the size is increasing on follow-up scans. There is evidence of Kesselbach-Merritt syndrome, then all of them are the candidates for surgery. If not, asymptomatic patients with an incidental finding can be observed on regular follow-ups. Right? The ideal surgery in such patients would be anucleation with inflow control. Anucleation with inflow control would be ideal surgery, but if the hemangioma is too large or if it is occupying a greater portion of the liver, then anatomical resections are necessary. Segmentectomy, hemihepatectomies are necessary. They have also tried RT and CT to reduce the size of the hemangioma, but this data is limited. Right? So right now, the ideal treatment is anucleation with inflow control. But if the hemangioma is too large or there are multiple hemangiomas, then anatomical resection can be considered. Right? In summary, hemangiomas are slow, indolent process in case of adults, and asymptomatic patients should be followed up. In symptomatic patients with specific indications, surgery has to be done because there is very less risk of rupture and the malignant potential is nil. That is why you keep high threshold for surgery. Do surgery only when it is absolutely necessary. So this is about a hepatic hemangioma. In children, sometimes they can also be associated with hemangiomas in other parts of the body, in other organs. And as I told you, there may be a high risk of AV shunting and congestive heart failure. And that's why it has to be managed accordingly. Right? So the next topic would be focal nodular hyperplasia. So focal nodular hyperplasia is the second most common benign tumor of the liver, and this FNH is again more common in females than in males. It is almost 8:1, 8 times more common in females than in males, and it is usually seen in middle-aged women. Okay. So what it means by focal nodular hyperplasia is that focally at one point in the liver, all the elements of the liver, so all the elements of the liver, the functional elements of the liver undergo hyperplasia along with the supporting stroma. Right? So all the functional elements of the liver plus the fibrous stroma undergo hyperplasia with a disorganized manner. So if you look at the histology of this focal nodular hyperplasia, there will be a central scar, and from this central scar, the fibrous septa will be radiated, just like a cartwheel or a spoke wheel. So this is called as cartwheel appearance. So from the central scar, there are these fibrous septa that are radiating, and this central scar contains an arteriole, And this arteriole along this septa has these smaller branches. So basically, this is a developmental vascular anomaly, right? So hemangioma was a congenital vascular anomaly. This is a developmental vascular anomaly, and some cases have been associated with consumption of OC pill use or have been attributed to hormones in the female. But this association is not so strong, and right now it is considered to be a developmental vascular anomaly where there is a central scar with central arteriole, and then there are smaller branches of these arteriole along the radiating fibrous septa. As I told you that it is because of the hyperplasia of all the functional units of the liver at a focal point. There are parts of this benign looking hepatocytes which are present along this fibrous septa. Also, there are Van Kupffer cells. So, even Van Kupffer cells are present, and there is scattered biliary epithelium all over. Right? So, this is very important. The scattered biliary epithelium and the Van Kupffer cells are seen in focal nodular hyperplasia, but both of them are absent in liver cell adenoma. So that is a differentiating point in histology. So this is about the histological appearance of a focal nodular hyperplasia. This central scar is seen in almost 85% of these patients, right? But there is a atypical form. So histologically, there is a atypical form of FNH which is seen in 15% of patients where there is no central scar. So central scar is not seen. That is called atypical form of FNH on histology. Now, this FNH is also having a classic form of FNH and a non-classical FNH. This classical FNH is what is we are discussing right now, which is more commonly seen in females, about 8 times more common in females. The non-classical FNH has following varieties. So it can be a telangiectatic FNH, or it could be adenomatous and hyperplastic FNH. Now, these two are non-classical FNH, and these two are more common in males. Right? So, this FNH, like hemangioma, has got a slow and indolent course, and that's why it does not produce any symptoms. The risk of rupture of an FNH is very, very low, and there is no malignant potential. Right? So, similar to that of a hemangioma, both of them are slow and indolent. The risk of rupture is very, very low, and there is no malignant potential. So, because it has got a slow and indolent course, the most commonly it will be asymptomatic. Right? If at all it increases in size, it will produce vague upper abdominal pain. And the gastroduodenal compression would produce vomiting. Right? So the physical examination will be unremarkable. Even the liver function test will be normal, except for the little rise in the liver enzymes, and the AFP will be normal. Right? So the mainly the diagnosis will be radiological, and you get an USG, it will be a firm mass. The investigation of choice is again a contrast scan and CT or MRI. Now, this will have a very strong uptake in the arterial phase. Right? So, in the arterial phase, there will be a very strong enhancement. And the central scar, which is there, it is not enhancing. So, a strong uptake in the arterial phase with a non enhancing central scar. But from the arterial phase, as it goes into the photovenous phase and into the delayed phase, there is washout of this contrast. So the contrast washes out, and in portal phase and delayed phase, it appears almost a same intensity or same density as it of a neighboring liver parenchyma. Right? So this is characteristic in CT or MRI. There's a strong enhancement in the arterial phase with non-enhancing central scar, But as it goes into protovenous phase and delayed phase, it becomes iso-intense or iso-dense with that of a neighboring liver parenchyma. So this will establish the diagnosis. Again, when you come to the treatment aspect, those that are asymptomatic, they only need follow. If they are symptomatic, again, you need to search for alternative cause of the symptoms. If there is no alternate explanation for the symptoms and the symptoms persist, or there is an increase in the size of this, or there is suspicious of malignancy, and you cannot confirm malignancy here because in all these cases the liver biopsy is either contraindicated, or even if it is done also, the yield is not much great. So that is why in cases of doubt and suspicion of malignancy is there, then you resect the tumor and send it for final histopathological examination to rule out malignancy. So all these are indications for resection. So this is about focal nodular hyperplasia. In short, focal nodular hyperplasia is again a slow and indolent growing tumor with very little risk of rupture and no malignant potential. So whenever possible, try to manage it conservatively by regular follow-ups. But if the symptoms persist and there is no alternate explanation, or there's a suspicion of malignancy, or the size keeps on increasing on serial ultrasounds, or there are mass effects, only then you go for surgery. Yes. So the next topic would be liver cell adenoma. This liver cell adenoma is again more common in females compared to that of males, and it is almost 11 times more common in females than in males. Most of the times, this liver cell adenoma is solitary. Right? Now, this liver cell adenoma has been greatly associated with use of OC pills. So, it is greatly associated with use of OC pills. In males, if they are using anabolic hormones, then there is risk of development of this liver cell adenoma. It has also been seen to be associated with FAP, and it has also been seen to be associated with certain other diseases like glycogen storage disorders type 1A. But most commonly, it is associated with OC pills. That is why it is seen in the age group of 20 to 40 years. So this is a classic liver cell adenoma. But sometimes what happens is this liver cell adenoma, and this is solitary and mainly seen in the right hemiliver. But sometimes there are multiple adenomas, and if there are more than 10 adenomas distributed all over the liver, then that is said to be liver cell adenomatosis. Right? Now, this liver cell adenomatosis, although more commonly seen in females, but it does not have this greater disproportion between the incidence in females and males. Right? So, this dramatic disproportion is not seen. Right? So that is one. And second, interestingly, it is not associated with the use of ossicles. Right? So these liver cell adenomatosis tend to be aggressive, right? And they need resection. And sometimes, if they are all over the liver and the resection is not sufficient, they might also need liver transplant. Right? But this liver cell adenoma, classic liver cell adenoma, is seen in the age of 20 to 40 years, 11 times more common in females than in males, and usually solitary, and it is seen in right hemiliver. This liver cell adenoma, if you look at histology, This is actually an increase in the number of hepatocytes. These benign looking hepatocytes are increased and the size of the hepatocytes also increased. So as the hepatocyte becomes bigger, it has got increased glycogen in it and it has got increased fat in it, right? So this is very important in diagnosis of this, radiological diagnosis of a liver cell adenoma, that these contain lot of fat in them. And these do not contain the biliary epithelium, right? So the biliary epithelium is not seen, the biliary ductules are not seen, the Van Puffer cells are also not seen. This is very important to differentiate it from a FNH. The biliary epithelium and the Van Puffer cells are not seen. There are increased number of hepatocytes. Hepatocytes are increased in size and they store more of glucogen and fat, right? This liver cell adenoma can produce symptoms. And the most common presentation in these patients is abdominal pain. So there is pain abdomen in these patients because it can enlarge in size, cause a stretch of the capsule, produce compression effects, and cause pain in the patients. So this is seen in almost 50 to 70% of the patients. And second, most importantly, liver cell adenoma can undergo rupture, right? So it has a risk of rupture seen in about 30 to 40% of cases. And the rupture risk is increased if it is more than 5 centimeter. Right? So the adenoma of more than 5 centimeter has the highest risk for rupture. If there is a rupture, it will produce intraperitoneal bleed and the patient can present in a state of hemorrhagic shock. And the third important concern in this patient is it has got a malignant potential. So this liver cell adenoma can lead to hepatocellular carcinoma in about 10% of cases, right? Again, the risk of malignancy is increased if the size of the adenoma is more than 5 centimeter, one. And second, if this has got a beta catenin exon 3 mutation, right? So beta catenin exon 3 mutation confers the malignancy potential to this liver cell adenoma, right? So 30 to 40% risk of rupture and 10% risk of conversion to malignant potential. There was this French collaborative group which gave this molecular pathological classification of liver cell adenoma. So according to this, some mutations have been identified, of which the most common is beta catenin, right? So they classified it as beta catenin mutated liver cell adenoma, and the mutation was one at exon 3 and one mutation at exon 7 or 8. So if this really is a beta catenin mutation, especially at the exon 3, and this has the highest risk of conversion into malignancy, right? While this mutation at exon 7 or 8, it has got no malignancy potential. So this was one. And second, it has also been associated with HNF1A mutations, right? So it is HNF1A mutated liver cell adenoma. And as I told you, it may also be associated with FAP. So, and the third is not otherwise specified, or it could be an inflammatory adenoma. And a specific pathway has sometimes been identified, which is called as sonic hedgehog pathway. And those which have got the activation of this sonic hedgehog pathway, these patients usually are obese and they have got the increased risk of rupture and bleed. So this is French collaborative classification, including a molecular pathological classification of a liver cell adenoma. So when you do investigations for this liver cell adenoma, as I told you that unless it turns into malignancy, the liver enzymes will be slightly raised. Apart from that, it is normal and AFP will not be raised. So the main diagnosis would be on scans. So again, the investigation of choice would be CT or MRI. Right? So as I told you that this contains lot of fat in that. So this will appear as a heterogeneous mass. So there is heterogeneity because of this fat inside. So this appears as a heterogeneous mass, and then there is a central peripheral enhancement with centripetal progression, meaning the enhancement happens at the periphery and it progresses towards the center, right? So a peripheral enhancement with centripetal progression plus heterogeneity, right? This tumor has got the risk of rupture. So when it ruptures, there will be blood, there will be necrosis, and fat. So this blood necrosis and fat give it the heterogeneity within that. So this is classic in CT or MRI, especially in a female patient of 20 to 40 years of age group with history of consumption of those pills. So how to manage these patients? Because there is a high risk of malignancy and rupture, there should be low threshold for surgery, meaning surgery should be done as and when it is deemed necessary rather than to wait. So if the patient comes to you, first group of patient comes to you with rupture. So whenever there is a rupture, there is intraperitoneal bleed, and because of this, patient will be in a state of shock. Such patient with resuscitation has to be taken up with embolization. Following embolization, it has to be resected. So if there is a symptomatic patient, again there is a tumor and that is causing the symptoms, it has to be resected. Third, if there is a asymptomatic patient and this patient is on OC pills, right? So in such patients, you can give an attempt to stop OC pills, and most of them will regress on stopping OC pills. If they fail to regress on stopping OC pills, it is better to resect them. And fourth, because it happens in the childbearing age group, so if there is a female who has got liver cell adenoma and she is planning conception, know that there is liver cell adenoma and she is planning conception, because of the effects of the hormones on this liver cell adenoma during pregnancy, it is better to resect them before pregnancy. So these are the four group of patients. So if you see here in the hemangioma and focal nodular hyperplasia, because of their indolent course and no malignant potential, it is better to go with a conservative approach there. But here, in case of FNH, in case of liver cell adenoma, because of the high risk of rupture and malignancy, it is better to go ahead with operative uh, maneuver rather than conservative maneuver, then there are clear-cut indications, right? So you keep low threshold for surgery. Do surgery as and when it is deemed necessary. So this is about the three major benign tumors of the liver. We'll have a quick revision of them by the comparison. So this is hemangioma, and then there is focal nodular hyperplasia, and then there is liver cell adenoma. So hemangioma is more common in females than in males, with a ratio of 3:1, focal nodular hyperplasia with a ratio of 8:1, and LCA with a ratio of 11:1. So all of them are more common in females than in males. So hemangioma is seen in the age group of 40 to 50 years. FNH is also seen in middle-aged women, while LCA is a disease of young women, usually in the age group of 20 to 40 years. Hemangioma is a congenital vascular malformation. FNH is because of developmental vascular malformation, and LCA is most commonly associated with ossicles. So in hemangioma, patients are usually asymptomatic. FNH, the patients are usually asymptomatic, and here most common symptom will be pain abdomen. About 50 to 70% of the patients will have pain abdomen, right? So the liver function tests are usually normal or slightly raised in all the three, and AFP will be not raised in all the three, and also in LCA until it turns malignancy, right? So the risk of rupture is very, very less here. Here the risk of rupture is also very, very less, and here it is high of 30 to 50%, especially if the tumor is more than 5 centimeters. The hemangioma has got no malignancy potential, FNH has got no malignancy potential, and it has got the malignancy potential of about 10% if the size is more than 5 centimeter and if there is a beta catenin exon 3 mutations. Right? So when you take CT or MRI, the hemangioma will have peripheral nodular enhancement. The focal nodular hyperplasia will have strong hypervascularity in case of an arterial phase with a non-enhancing central scar. And this becomes isodense or isointense as it enters the photovenous phase and the delay phase. The liver cell adenoma, when you look at CT of a liver cell adenoma, it will be heterogeneous owing to the fat, blood, and necrosis. Okay. When you look at histopathology, hemangioma has got a dilated lead-filled spaces with fibrous septa in between. The focal nodular hyperplasia has got a central scar from which contains an artery, and from there are these smaller branches which radiate along this fibrous septa in a cartwheel manner, and then there are parts of hepatocytes. So it is all the functional elements of the liver have increased in number and in size. Especially it has got a van Kupffer cells and atypical biliary epithelium distributed all throughout. The liver cell adenoma has got an increased size of the hepatocytes, increased number of the hepatocytes, and these contain increased glycogen and increased fat. But what it lacks is a van Kupffer cells and biliary ductal epithelium. Right. So when it comes to treatment, hemangioma and FNH have to be observed, and only when there is an obvious need for surgery, they need to be operated. On the other hand, liver cell adenoma, it is better to go ahead with surgery whenever there are these indications. Right. So this is in short summary of FNH, hemangioma, and LCH. There are other benign tumors of the liver also. For example, there is macro regenerative nodules, and there is regenerative nodular hyperplasia. Macro regenerative nodules were initially called as adenomatous nodules. So these are more than 2 centimeters. They are seen in patients with cirrhosis and they have got a malignant potential. While regenerative nodular hyperplasia has got diffuse nodules of less than 2 centimeter, it is not associated with cirrhosis and it does not have malignant potential, right? So this is usually seen in patients with a collagen vascular disease, in a lymphoproliferative diseases, patients who are on long-term steroid use, and patients with chemotherapy. In such patients, diffusely small nodules will develop, but they are indolent, they do not have any malignant potential, and it is not associated with cirrhosis. But macro-regenerative nodules are because of cirrhosis, because of the chronic inflammatory process, this will lead to the hyperplasia. So whenever there is hyperplasia, that will produce these big surface nodules which are bile stained. So bile stained surface nodules of more than 2 centimeters are seen, which are associated with cirrhosis and have got a malignant potential. So there is one more entity which is called as mesenchymal hamartoma of the liver. So this mesenchymal hamartoma of liver is usually a solitary lesion and it is seen in the right hemiliver, especially in childhood. And this can produce a large cystic mass. It's a large cystic mass, solitary, seen in children and especially in the right hemiliver. So this treatment is excision, right? It has to be excised, it has to be resected. So the treatment is resection of this large mass as it causes compressive symptoms. So then there are fatty tumors of the liver, benign fatty tumors of the liver. So there could be lipoma in the liver, there could be myelolipoma, which contains the hematogenous tissue also. There could be angiolipoma, there could be angiomyolipoma, which contains blood vessels and smooth muscle fibers, or there could be myolipoma. So these are all the fatty tumors. These are benign tumors of the liver. Now we'll see some images. So here, if you see, this is a CT scan with contrast CT. You can see that there is a heterogeneous lesion. So this is all hypodense, and this is little more hypodense, and this is isodense that of the liver, and this is hyperdense to liver. So this is a heterogeneous lesion, a solitary lesion in the right lobe of the liver. This is usually suggestive of liver cell adenoma. And then if you see here, there is this lesion. This is an MRI picture. There is this lesion in the liver. And you see that this is the arterial phase. In the arterial phase, this liver, this lesion has got a strong enhancement, but except for the central non-enhancing area. So this is the central scar, which is not enhanced, and there's a strong enhancement in the arterial phase. But you see, as it goes into the venous phase and delayed phase, this becomes almost iso-intense. This is the MRI, so it becomes almost iso-intense with that of the surrounding liver. So this is again the central scar, right? So there is a central scar. This central scar is non-enhancing, and there's strong enhancement in the arterial phase. But as it goes into the portovenous phase and delayed phase, it becomes iso-intense with that of the surrounding liver parenchyma. And then this is one more CT scan. So on the non-contrast CT, you can see that there is a lesion which is hypodense than that of the surrounding liver. Now in the arterial phase, you can see that there is peripheral enhancements, right? So as it goes into photovenous phase, the enhancement in the periphery further increases, right? So there is homogeneous non-enhancement in the center, but on the periphery, this keeps on increasing. So this is a peripheral nodular enhancement. And this enhancement slowly progresses inside. So in the delayed phase, almost this entire thing is enhanced. So this is hemangioma of the liver, where it is hypodense in a non-contrast CT, and in the contrast CT, in the delayed phase, there will be more enhancement, and this is a peripheral nodular enhancement. This is the central scar and the central arteriole, from where there are radiating fibrous septa, right? So central scar with radiating fibrous septa, and along this fibrous septa, there is the functional hepatic parenchyma, right? So there are hyperplasia of almost all the elements of the liver. So this is suggestive of focal nodular hyperplasia, right? And then this is where these are all the sinusoidal spaces. So these sinusoidal spaces are dilated. As I told you, this is mainly because of ectasia rather than neoplasia. So these are all the RBCs within the sinusoids, and these are all the spaces where they are dilated and they are separated by this fibrous septa. So it is a case of hemangioma of the liver. So this is all about the benign tumors of the liver. In the next class, we'll discuss about the malignant tumors of the liver. Thank you.